Good morning, everyone. I'm Dave Rosen. Welcome to another edition of Surgery Live. Very excited to have you all here for our first episode of 2021. We're really privileged to have Dr. Ponsky moderate this and Dr. Gorgun present, two of the world's leading experts on surgical endoscopy. And so with that, I'll give it over to you, Dr. Ponsky.
Well, thank you very much. Thank you very much. I have to say, I've been doing endoscopy and working with endoscopists for my entire career, a long time. And once in a while, you see someone who is a little bit different than everyone else. And when I began working again at the Cleveland Clinic about 7 years ago, I ran into Emre Gorgun and I walked into his room to see what he's doing. And I saw the quality and technical difficulty of the cases that he does, and they're really remarkable. It's a cut above what I do and what most people can do. And he's introducing an entirely new area in surgical endoscopy and endoscopy in general, and it's wonderful and remarkable, and he's going to tell us a little bit about it today. Dr. Gorgun is the head of the section in colorectal surgical oncology and the head of endoluminal colorectal surgery. And he's probably the leader in the United States in colorectal ESD. Nobody can increase over the numbers of the Japanese, but he's the leader in the United States for sure. And without any further ado, Emre, please carry on.
Thank you very much, Jeff. Very kind introduction. I'm honored to hear your comments, and I really appreciate that. We learn a lot, and your innovative mindset also definitely helps us to drive our innovations here at the Cleveland Clinic Main Center. So I'm going to talk about endoluminal surgery and some of the innovative aspects of ESD, as well as advanced endoscopy, especially in the lower GI platforms in the colon and rectum. So these are my disclosures. So outlines of my talk is definitely I'm going to talk about polyps, endoluminal surgery, and I want to touch on endorobotics, which I'm very excited about this item that I think this is up and coming, and I will share with you why I think so. But definitely everything is with grain and salt of my own bias here. I just want to put that out there. Jeff mentioned we doing these extreme cases, but I want to a little bit mention why we are doing those. And one of the main reasons is obviously we live in a country that screening is very well established. And this is very good news. That helps our community to have less cancers. But at the flip side, there are always more polyps are found. 1 in 6 Americans will definitely form an adenoma. And this is a very recent publication from U.S. Preventive Services and Task Force. As you might heard, that the colorectal cancer screening is actually now officially dropped down to 45 years old. So with that, and this is really recent, October 2020 published, and this is gonna also help the payers and insurance companies to accept this as to be reimbursed. So this is certainly a positive development for us. Okay. One other thing I'm going to start asking is, are you performing flexible endoscopy as your part of your surgical practice? If your answer is yes, I think you are on the right track, definitely, because this is, in this era, in this day and age, we cannot consider a good surgeon, quote unquote, without being able to do colonoscopy or endoscopy. For lower GI, I can tell you that for cancers, rectal cancers, we need to scope them for even which part of the organ is diseased. So flexible endoscopy is a must. And we also know that a large number of patients, 30,000 per year, undergo more major surgical resections for benign polyps. So this is a gigantic number, really large, for colon resection or proctectomies. And this is in the United States. Imagine what this number may look like globally. This is a very interesting study from an inpatient sample that looked at for 14-year period that for all colon resections and colectomies, 25% of them of these were for an etiology of non-malignant polyp for a benign reason. This is really dramatic. So 1 out of 4 patients go major organ resection for a benign reason, and also this study found from 2000 to 2014 was the study period for this in this paper, and the number of these cases actually even increased between these 2 dates. And also in contrary, the number of cancer cases decreased. Again, more screening, of course, we finding them before they turn into the cancer. So that certainly is the cause of that. One might say, so what? I mean, we take the colon out, right? Hemicolectomy, easy. No, this is another nice paper looking at this from an inpatient sample as well for 10-year period. They almost close to 1% of these patients die when they have an organ resection. And not only mortality is a risk, of course, these patients have also complications and morbidity. And we know that with these increased morbidities, postoperative length of stay, hospital cost increases. This is another interesting abstract that caught my eye on last ACS meeting when we were still doing in-person meetings. And there is a huge discrepancy between states also in terms of colon resections for benign polyp reasons. And this is even up to 69-fold difference. This is major. And one of the reasons that the authors concluded is limited access to advanced endoscopists or skilled centers, and that leads to more organ resection. This is really, in this day and age in the United States, something that we should do better, and that's what we are striking for and aiming for. And in real life, how does that look like? You come and see someone like this, and this is a real patient. This was a very nice female chef from Iceland that married an American senator, actually moved to the United States and was referred to me with this lesion. Yeah, it has some non-granular appearance, some areas for suspicion, and a lot of centers could treat this with a laparoscopic right hemicolectomy or piecemeal polypectomy. But really the way to go for these is advanced endoscopy and en bloc resection, because there is a possibility with this non-granular feature, some of the surface anatomy features that may carry cancer. So you might want to get a full thickness en bloc specimen and certainly get a good history. On the other hand, again, there are always the thought that what if this harbors a cancer? We can remove them endoscopically, but there's a concern. We looked at that at our center as well, published in 2016, for colon resections performed for unamenable endoscopic removal for benign polyps. The final pathology only revealed 8% of the time colon cancer. So really that incidence is very, very low. And majority of the time, these are benign polyps. And I believe if we pre-select these patients even, that number is gonna be even much smaller. So for advanced endoscopic approach for benign polyp is certainly the way to go. And therefore we do EMR, endoscopic mucosal resections, which I'm not gonna touch on, but I'm gonna go a little bit more advanced today for the sake of time. ESD, endoscopic submucosal dissection. As a surgeon also, we can certainly do combined endolaparoscopy, laparoscopic approach. And what we also collect is under the umbrella of endoluminal surgery, maybe even do more advanced procedure by bringing more surgical instruments into the space, into the lumen. And we're gonna look at that as well shortly. So ESD, what is the ESD? It's an advanced endoscopic procedure, was popularized in Japan and Korea, mostly in Asian countries, because of the experiences that they gained from gastric cancers. And the idea is to inject submucosally, like you see at the bottom side. And these are the steps you can see. And from A to F, you can mark or inject. Then mucosal incisions are made. And then submucosal dissection. As you see, the cap is a critical portion and instrument that you need or tool you need. And then subsequently retrieving and observing this, the resection site. You can clip that if you will, and then finally getting an en bloc resection and better histopathological analysis. So what tools do we have? Definitely a cap, like mentioned, is needed. That helps to get into that space, into the submucosal space, and create some traction. Then there are these special knives, tools, graspers. Like this is not our classical biopsy forceps. It has flat surface, so you can, like a DeBakey, surgical DeBakey, stop the bleeders. Hook knife. The upper ones are mostly upper GI, so I'm going to skip that. But colorectal ESD, we have more limited tools, which makes it easier. I'm going to go quickly about this. This is the knife typical we use. There's also a form that we can use with the injection as well, dual knife that comes with a pump. So as you cut, you can further inject fluid into the submucosal space as well. The hook knife is like for surgeons' gallbladder, when we do gallbladder resections, that looks similar to that. I don't routinely use this, but something that you can just to know for knowledge, it exists several times, or very few indications can be helpful. Co-grasper, it's a good tool, very good tool. It's great. Like I said, it's a flat jaws, and that helps with the bleeding. And I have a video that we can look at that as well. This is something I can't skip. Energy is also important to mention when we talk about endoluminal surgery, because it's not our routine surgical valley lap or these ligature tower type generators that we can use. These are more specialized endoscopy towers, either Olympus Thunderbeat generator or ESG 400 or Irby generators. These are the ones that most commonly used in the United States, at least. And they can, the advantage of these are they can blend coagulation and cutting, and also you can put in different modalities like cut intervals, cut duration, and also effect of deep penetration. So you can control the energy very precisely to prevent complications. So this is an important aspect to know. Injection solutions are also as important as generators, because this is also a key component of the successful procedure. Certainly we didn't have in the United States any of these fluids in the past. More recently, FDA approved a few of these like Oragel or Elaview, and they really helped significantly with the procedure. But despite all these instruments or tools available, the methods are not widely used. The ESD is not widely used in the United States because the needed skills to perform ESD is still very hard to acquire. It's a technically very demanding procedure, and a learning curve is very, very high, long, steep. Therefore, there are now technologies out there that hopefully will enable these procedures for surgeons, where we can really do more, get into the space of endoluminal surgery, do resections, cuttings more easily, not just like a rhinoceros, like one hand tied behind, but with two-hand operations where we can get traction and counter traction. For example, this is the tissue resection system from Boston Scientific. Guy Lumen. Metrobotics is a flexible semi-robotic platform, which and Da Vinci SP is also a semi-robotic platform. And there are other companies like Oris, for example, fully robotic platforms that are work in progress, that hopefully in the near future we will be able to utilize it. These more specifically newer technologies, these I'm gonna get into those a little bit first, which I think gonna be a segue into the future of endoluminal surgery. For example, this is the Boston Scientific one, the blue over tube with it provides a cage at the end of the over tube, and you can control that from outside. And with external channels, also bring graspers, retract the specimen, and you can here so nicely see the muscular layer and the submucosal layer, and you go in and en bloc fashion resect. These are how we position our patients in the operating room in a semi-lithotomy position, and have our monitors available. Of course, especially when you introduce something like this new, you always want to have the ability to use laparoscopy if you need to. But as experience builds up, the need for that is certainly not any longer there, because you can manage to get lesions, even like this, large lesions out without any problems. Here, this was a lesion, the rectal lesion, starting very low but expanding up to upper rectum. You need to make the cuts. You see the dual knife in action, and you see how efficient it is. Here now, once you circumferentially make the cut, mucosal cut, here you see the delivering of the cage and the channels retraction. And this is, endoluminal approach for something that with flexible endoscopy we would never have this type of ability, where now things are certainly much different, and traction and countertraction is applied. You see things are much faster with this type of speeding component, and you see it's a large segment, can be removed even up to even 360 degrees of circumference in the lumen. For example, this patient had a 14 centimeter lesion and went home very, very quickly, same day actually, without any problems. And follow-up colonoscopy was fine without any recurrence. And then you also get this type of histopathology where, if there's even the basal membrane muscularis mucosa is broken, you know it. And depending on the depth of penetration, you can certainly be certain whether you need to do anything further, organ preserving or organ resection. The other item is the balloon port, the dilumen. That's another innovative platform. You see there are two balloon ports, foreballoon and aft balloon, and they are again side channels, and you can bring instruments as well. The instrument looks like this in overall the C2 platform with the grasping channels, and then also the handles can almost like a single port instrument. That articulation is certainly there, and in the operating view is on the right hand side. The balloon is inflated from an outside controlled handle and 4 balloons, and the whole platform is brought into the space where the colon lesion is. This is, for example, a lesion in the upper rectum again. And obviously, each time you introduce something new, I always try to start in a more controlled area, which rectum is always. But here again, this is not TEMIS, or this is not TEM or anything like that. Fully flexible endoscopic platform. And CoaGrasper, I mentioned earlier, it's a beautiful tool. These penetrating vessels, you can prophylactically grab them. And this is, don't get it wrong, this is not surgery, like real surgical area. This is all flexible endoscopy, but it looks like surgery because that's why we like to call it endoluminal surgery. Instrument mount on the right upper side, as you see here. This is another one. This is now, as you build your experience, you can, of course, then take it always to the next level, like our careers. And this is a lesion now at the ileocecal valve. Again, you see the grasper is coming into the right colon. This is revolutionary because this is really something that we were not able to do before. And you can appreciate the degree of traction that this grasper is providing us. And you can also imagine how much faster this can make the procedure. Again, the bottom on the left, you can see the muscle layers. You exactly know where to go. That bluish area is your submucosal plane. You use your dual knife and in a fast fashion, cut it. For the sake of time, I'm going to keep moving here. again, the grasper is holding the whole the whole lesion, and it's not a small lesion. This was about 5.5 centimeter lesion, and here you go. Again, the grasper is holding it, and then you don't even need a retrieval back or a rough net. You can just grab it back and pull it out and pin it down. These are our experiences. This is the largest series, to the best of my knowledge, we're using with this enabling technology, and majority of more than 50% of the cases so far we have done proximal to the splenic flexure. So this is, again, I think a step forward to enable endoluminal surgery, where we have really active traction using these external grasping devices. And this is now the endorobotics. Of course, flexible endoscopy is one thing, but look at the dexterity and control of the field with the robot. Of course, this is from outside controlled, and this is ESD being performed. This is probably also one of the first usage of endorobotics for ESD purposes. It's not a full thickness excision. It's in the rectum, but these can be reach up to 24 centimeter. But again, and there's flexibility on the instrumentations as well. But the goal is, of course, if these robots could be developed, and suturing is also possible with that. If these robots can be fully developed to, the lesions are also large lesions can be removed, to fully flexible, that to the point that we can deliver these fully flexible robots anywhere in the colon, that would be extremely innovative. So endoluminal surgery, we need certainly to be able to do more, and we need surgical and endoscopic evolution and innovation, so we can do more. And we do more. For example, when we do more, we're gonna get into perforations, rupturing the intestine, we're gonna get stricturing, and we should be able to use also endoscopic clipping, Ovesco over the scope clip to close our defects. Endoscopic suturing, Dr. Ponsky always talks about that, which is very important, and that's gonna make another leap forward in endoluminal surgery, I think, but we need better, more user-friendly devices for that, and of course, balloon dilatations and sinusotomies. With my co-partner, Dr. Ahmet Butt, to make this field more developed, we developed the Endoluminal Surgery Center. I welcome everyone to go and check on our website, and this is a good tool for information, for patient streaming, appointments for our patients, and so we can reach out to more patients and help out and do organ preserving approach for these patients. These are our Cleveland Clinic ESD experience over the years, endoluminal approach. And as you see, there's a huge, really during the last couple of years, our experience grown significantly, and this doesn't include 2020. We are close to 700 numbers now. Our early experiences are published. For the sake of time, I'm gonna go quickly here. Our cancer risks or cancer indication at the final pathology is extremely low. Of course, we pre-select these lesions as well, and our perforation rate, readmissions rates are all very low and consistent with the literature, if not better, and definitely much better than or after organ resections. And one last thing, that of course, what the cost, it's in a case match study, there's, even with the earlier experience, now we are more experienced. Majority of these cases are done in the outpatient settings. When we were used to do them in the operating room, the ESD has definitely 43% cost reduction for right-sided lesions. So there's certainly a great advantage. And so in conclusion, these techniques will evolve and innovation will occur, and we need to, as surgeons, certainly stay in control. But I will say embrace endorobotics, because that's coming. But certainly endoluminal surgery is a leap forward in the surgical field, and you'll be hearing more and more about this in the future. And I want to finish up with something that I learned and heard from my good mentor and friend, Dr. Ponsky, and I try to remember that every time I do any of these procedures. If you're not living on the edge, you are taking up too much space. And with that, I'm concluding my talk and happy to take any questions, if any. Thank you.
Emre, that was just fabulous. I only wish that we had 4 hours to discuss every detail and question that I could ask you, and we will have a conference about this at some point. I want to just congratulate you on all this wonderful work that you're doing. Some of these cases you actually do under conscious sedation without general anesthesia, and that's even more remarkable. I just want to congratulate you on your great work. Let me just start the questions off with saying, are there any things that you do when you go in to look at one of these lesions that warn you not to try an ESD? That what is the red light that stops you, that tells you this thing is going through the wall or it's too thick to do an ESD?
Yeah, I mean, I start out with first pre-selecting these patients. Definitely look at the colored images. I always request to get, because when we get these referrals, we always get these faxed results, and you can't tell anything. So even before signing them up for an advanced endoscopic procedure, I look at these colored images. Like you mentioned, morphology, this surface anatomy, if there is any significant central depression, the loss of pit pattern or anything like that, then certainly these patients are most likely not good candidates. There's a good chance that these patients can carry cancer, and those can be referred directly to surgery or intraoperatively, intraprocedurally. If you, of course, get into that space and in the submucosal area that the lesion is penetrating into the muscular layer, then that's also a red flag that may indicate the cancer. Having said that, sometimes these lesions are scarred down due to previous attempts, so that's something that we gotta be also be cautious when we are evaluating these.
I want to encourage the audience. We have a few more minutes to post your questions in the chat area so that we can answer any questions. I just want to ask one more. When most of us don't do ESD, but a lot of us do EMR. When can we do EMR in some of these lesions? What is the real difference in outcome between the EMR and the ESD?
Excellent question. EMR is, I think, a great tool in the colon, and and there's a huge role for that. Michael Berg from Sydney only recommends EMR. I think he's a little bit taking it to the too extreme. For lesions that are concerning, like that woman from Iceland I showed, there are some laterally spreading tumors, non-granular, high potentially risk for high-grade dysplasia or invasion. You got to take these lesions as an en bloc fashion, but we get very comfortable evaluating these lesions as we keep seeing these lesions. Some of these are sessile serrated polyp. You look at them and this is benign or very granular. There's no risk for invasion. These you don't have to waste time with ESD. Those I do injection, good, but really a formal EMR mucosal resection, large area resected, so the recurrence is low. If you do a suboptimal resection though, with EMR you can have high recurrence rates, so that's something that you don't want to get.
Okay.
Emre.
My good friend Peter, I see him. I miss him because we used to run these courses for years, but now
you'll see. I've got my ski sweater on because I'm calling you from the slopes of Sugarloaf. I'm off today.
Making me jealous.
I'll be on the slopes at 8:30. Listen, great talk, Emre, as always. And I know you've done a lot of continued work. A couple of questions. Have you tried yet doing endoscopic full thickness resections? And if so, do you think that's where we're going?
Not intentionally, but unintentionally, sometimes maybe intentionally getting there as well. Even in an outpatient setting, I feel comfortable doing endoscopic full thickness, and I'm not giving up when I do that. Patients bradycardia, especially if they are under conscious sedation, but we have excellent now endoscopic clips, endo clips, and I securely close them. For example, just last Monday, I did one polyp in the diverticulum. So these, basically there's no muscle layer there. It's by definition, it's going to be a full thickness, and close them with an over the scope clip, So I think that's where we are getting as we get better with these and endoscopic suturing. I think that's going to get us lead into the nodes even. And that's the future for sure.
Well,
So,
I think that's where we're going.
Peter, go ahead, finish up.
I was just going to say, I think that is where we're going. And I've done a case where I looked at the risk of surgery for the patient was high. The risk of endoscopy was certainly a lot less. And I purposely went full thickness and then suturing, closing. And I think suturing is the key. What do you think, Emre? What other tools do we need other than the suturing and the ability to retract or countertract?
I think so. I've used this Dilumen like 17 cases. I think delivering the platform up to the lesion is a little bit difficult, but I've been many times on the right side. I think this is really tremendous. Of course, the platform has to be a little bit better, but that way you can bring the grasper in, and it's pretty precise where you can really address and pinpoint down to the area where you want to retract. So I think that's where we are heading. Also, these over tubes you can use also, for example, if you're going to use endostitch or Apollo, you can take it in and out, change the stitch, and suture these defects as well. So,
for you, frustrating part during the case that kind of gets you anxious? Because I know what it is for me. I just wanted to know your experience.
So, which part you saying?
Yeah, when does it get most frustrating or anxiety?
Yeah, so especially when you are if you can't get a good retraction, you can't use gravity, you can't get under the lesion, or you go, but the you don't have a good visual appearance, good visualization of that area. One thing, and the other main frustration for me is when I get into a big bleeding, because different than laparoscopy, when you get bleeding, that's sometimes, it's somehow warm or something, your lens gets blocked. So that's the worst thing, but there are ways to get away with it as well.
I think the field will be limited until we have advanced endoscopic energy to manage these tiny little vessels that are just so frustrating. So,
yeah,
I think we need tools energy tools for bleeding to make these resections be safer, and then I think that'll lead to the next levels. But I congratulate you on all the work that you're doing. I look forward to us getting together again and keep pushing it forward. So congratulations.
Likewise, good to see you.
Let's have one final question, and I think we have to. They're going to get after me. So, Dr. Wexner, finish it up.
Yeah, thanks very much, Dr. Ponsky, and congratulations, Dr. Gorgun. Outstanding talk, as always, really informative. With your level of technical wizardry, it looks simple, right? You show videos, everything looks great, and even though Dr. Marcello asked what part gets you a couple of palpitations, maybe it's little vessels, the part that you didn't discuss is how do you get there? So what is the learning pathway? We heard about courses. How does one get this level of expertise? And has anybody looked at the learning curve to know how many cases you need to do and at what point you start tackling bigger and harder to move around lesions?
Yeah. For me, for Peter, I think it was harder. For Larry Whalen, when we started, because we didn't have any courses, etc. But we went to Japan, to Australia to observe. I think now our surgeons in the United States have a little bit maybe more resources. So these courses certainly one thing. They are also we delivering like with Dr. Ponsky, we're doing intramural courses here every year at the center. Tolga has some down in Florida with you, Dr. Wexner. So there are now more resources. These are really crucial. These are very important resources for us. And then as surgeons, I think we got to start at some point. Of course, the lab also, I need to mention before, X-Lab, in the animal labs, in the explant, practicing many times before you trial it in a human, because it takes one stroke, I say, when you do it in a human case to just perforate, and kind of, I call it game over. It's really hard to reverse that back. So you really practice on an explant before you go live case. But then we also have another advantage, like if you're not feeling comfortable, do them all in the operating room. Use laparoscopy if you need to repair those defects immediately. And as you get better, the need for laparoscopy will not be there anymore. That's how I switched from inpatient to OR to endo suite, because I was wasting my OR time. So that's one thing. In terms of the learning curve, there are different data on that. Some say 40, 50, but more reliable data, I think it's more leading 100 and over 100 cases. So it is a technique that is a highly technically demanding. Therefore, I think these endoluminal platforms, retraction devices, endorobotics is gonna make the trick, give us a great opportunity to advance this field even further.
Thanks very much. It's reminiscent of the early days of laparoscopy, as Jeff and I can certainly attest. And Peter, that when we started out in the late 80s, there were no courses. We sort of made up the courses as we went along, and then the learning curve numbers increased from 20 to 40 to 60 to 100. The more we did, the more we realized in retrospect we didn't know what we were doing further and further along, and ultimately that number went up. So it sounds like a good parallel. Doing it in the operating room is smart. I mean, again, Dave Beck did that in the early days of laparoscopy. Wrote about that before we had caps and all of these energy sources, just more like big polyps. So I commend you again. Thanks.
Thank you.
Dr. Rosen, I'm going to turn it over to you to finish up for us.
Great. Thanks so much, everybody. Wonderful presentation, Dr. Gorgun. Great discussion. Thanks, everyone, for logging in. Great way to kick off our 2021 Surgery Live series. We'll be right back next week on Friday the 15th at 6:45. Dr. Amy Leitner is going to be presenting on a topic with one of our fellows, Dr. Berger, talking about a case of dysplasia in ulcerative colitis patient and how we would manage that. As a monthly reminder, Surgery Live meets every Friday except the first Friday of the month, so second, third, fourth, fifth Friday, and we rotate through all the general surgery subspecialties. We also have a sponsor for 2021. Medtronic is helping us sponsor and get the word out about this series, so we're very appreciative to them. And thanks again for joining, and we'll see you next week on Surgery Live.